My name is Shane Solger, hard G. I'm one of your PGY5 EMIMs, and we'll be talking about quality metrics. This is going to be our lecture outline. So we'll talk about CMS as it relates to quality, the history of these metrics, how the metrics are tied to the money. We'll talk about the awesome model, which we'll go into what an APM is later. We'll discuss how these metrics are made, and we'll talk about the double-edged sword of quality metrics. So the reason that we care about quality metrics is because CMS has tied these to our reimbursements. This is the definition that I pulled from the EMIRAT Advocacy Handbook that defines what a quality measure is, and it's pretty self-explanatory. A quality measure is functionally just a benchmark that CMS has decided has indicated some sort of quality, and how well you meet these benchmarks determines how much money you get from Medicare. So, the spirit of the initiative is that physicians who follow these markers of high value care are reimbursed better. So, essentially, CMS is rewarding what it sees as good behavior to make the money that we spend on healthcare more efficient. The double-edged sword with this process is that the money and reimbursements then can incentivize the practice of emergency medicine, and a misguided quality metric may influence physician practice in a way that might hurt patients. So, kind of to understand where we are now, we'll just kind of briefly discuss how we got here. So, in the early 2000s, the Hospital Quality Alliance began measuring markers for quality around disease processes like heart attacks, CHF, stroke, and pneumonia. And one example that we're familiar with is the percentage of patients who made it to the PCI within 90 minutes of their hospital arrival. In 2004, the JCO and CMS began to collect performance data on these measures and to publicly report it on their website. And so 2004 was the first time that comparative data was actually made available both to the public and the payers. In 2006, the Physician Quality Reporting System, or PQRS, was created by CMS. It was initially meant to be an incentive program, so those providers who took care of Medicare patients could receive an extra 1.5% of reimbursement for submitting quality metric data to CMS. And it was during this time that ACEP developed quality metrics for diseases like PEs, ectopic pregnancies, and abdominal pain. And then in 2015, the Medicare Access and Chip Reauthorization Act of 2015, or MACRA, created the Quality Payment Program that started in 2017 to replace its incentive program that rewarded or penalized patients based off of their compliance with these programs. There are two ways to participate with the Quality Payment Program. One is through MIPS, which is the merit-based incentive payment system, and the other was through an advanced alternative payment model, or an APM. And then in 2023, they began the MIPS mean value pathways, which is a specialty specific way of participating in MIPS. And we'll discuss that a little bit more in detail later. So next, we're going to dive into how these different quality metric programs lead to physician reimbursements. So just focus on these two over here on the sides. But as I'd mentioned, there were initially two ways to participate in the quality payment program through MIPS or through an advanced alternative payment pathway or an APM. And so MIPS came about. MIPS consolidated three different performance-based programs. That you had the PQRS, the value-based payment modifier, or the VBP, and the Electronic Health Record Incentive Program, which was also known as Meaningful Use. Prior to them coming together, you were incentivized with money to comply with each of them separately. However, because each of these programs could independently penalize you, some physicians received double-digit cuts to their Medicare reimbursements, and so that was the reason to consolidate it into one program. As emergency providers, it's more likely that we're going to interact with MIPS because if you fulfill certain criteria, such as billing for more than $90,000 a year, seeing more than 200 patients, and providing more than 200 different services, you actually have to partake in MIPS, which most EDs will fulfill these criteria. The only exceptions are if you don't meet these minimums, if you're a brand new enrollee to Medicare, if you're not considered an eligible physician, or if you're participating in an advanced alternative payment model or an APM. So this graph explains how the program generates money and how it pays it out to physicians. MIPS is a net neutral program, so that means that you can't pay out more money than you take in. there's kind of an expectation that a lot of places aren't going to participate at all and that they're forfeiting their upwards of 9% of their Medicare reimbursements as a penalty. So the more that you submit and contribute, the more that you're expected to be reimbursed for following the quality metrics. Unfortunately, even though maximum reimbursement is 9%, it's not guaranteed. An example of this was in 2022, where if your group scored 100, which is the maximum number of points that you can get, your payment was only adjusted by 2.3% because more groups were compliant and they're reporting with their reporting and they scored well. So if everybody does well, unfortunately, that means that you get less. So, how do we get these points? How does it all work? Well, the physicians or groups submit information based off of quality metrics, so quality, improvement activities, and promoting interoperability. And the cost is calculated from the claims that you submit to CMS for payment. CMS then gives you a score of 0 to 100, which determines if you receive a negative, neutral, or positive MIPS payment. And that's applied to your Medicare Part B covered professional services. And there's a 2-year delay. So, however you perform in 2023 determines how you get paid in 2025. So, for the quality performance piece, there's actually 198 quality measures to choose from. For improvement activities, you get to choose from 106 different activities. For promoting interoperability, it's based off of 4 areas, and cost is determined from 25 different measures. So, to not get a penalty, you need at least 75 points. And these points are based off of how well you do on the metrics that you submit to CMS. A benchmark refers to the goal of the quality metric or how much of that metric that you do to get points. A threshold refers to the 50th percentile, and the benchmark usually means some sort of top percentile. So, if this is a benchmark and this is a threshold, if you do not meet the threshold, you do not get any points. If you make it between the threshold and the benchmark, then you'll get anywhere from 1 to 9 points. And if you meet the benchmark, you get full points or 10 points. So again, this is just to show you how reimbursements were doled out and collected for 2023, with a reminder that you get paid 2 years afterwards. So you see that 75 points was sort of like your net neutral. Anything below that got you less money, and anything above 75 points got you more money. So, there are organizations referred to as qualified clinical data registries, and these are third parties that report to CMS on an ED's behalf. CEDAR, the Clinical Emergency Data Registry, was created by ACEP, and it's an EM-specific qualified clinical data registry. And so what that means is that an ED will pay CEDAR to take data from its EMR and submit this data to CMS to fulfill that MIPS reporting requirement. And this ideally allows the emergency department to get the maximum amount of money for their Medicare patients. But CEDAR doesn't just intake data and spit it out to CMS. It also provides it back to the emergency department group that purchased the services. It provides feedback to the EDs to let them know how they're doing in terms of providing quality care to patients based off of the ED specific metrics that they've developed. Some of these quality metrics include information about a department's use of antibiotics for URIs or the department's use of CTs for minor trauma. CEDAR also provides data to a lot of our national healthcare organizations like the CDC and the NIH to support a lot of different projects. So in 2022, this was the division in terms of reporting possibilities. However, as of 2023, they added this one, the one that says new. And so there's these new MIPS MVPs created because of the confusions that a lot of doctors expressed with having more than 190 options for quality across every subspecialty that could be reported through the traditional MIPS program. The MVPs are anticipated to be the future of the program going forward, and they're quality metrics that are designed around different subspecialties and medical conditions. At present, there's 12 MVPs, and only one of them is for emergency medicine. So this just puts into view the timeline for what I had previously mentioned. We can see along the top that the traditional MIPS has an endpoint right here. And then we see that MVPs and APPs are the future as this kind of gets phased out. So we can see that this arrow kind of keeps going. And so if you click around the CMS website and explore the different quality metrics, you'll find the ED specific ones, such as these. An ED is required to select at least 4 quality metrics from this list, and one of the measures must be an outcome measure. And here we can see that they have priorities assigned to them. And this is really relevant for us because we do have an outcome measure available. But if we didn't have an outcome measure available, then we would be able to select another high priority measure instead. And so I'm just going to briefly go through what one of these looks like. So this is the adult sinusitis and antibiotic prescribed for acute sinusitis overview. And so you can see that it talks about like what it is. It talks about its priority. It talks about who its denominator is and how it pulls it based off of your ICD-10 coding. It defines what it is. So 4 weeks of purulent drainage. It talks about what your numerators are and what a performance met means and what it does not mean. So if you gave antibiotic regimen prescribed within 10 days of acute onset symptoms, that means that you did a good job because you waited your 10 days, and then you didn't meet it if you gave it within that first 10 days. It talks about the rationale, so the evidence behind their decision, talks about what their actual recommendation is for care, their copyright data, and then they also have all these different like fun algorithms because we're emergency medicine and we love algorithms. But that's what one of these looks like in a nutshell. All right. So what about those advanced payment models or those alternative payment model plans that are supposed to be the future? Well, ACIP is working on its own. This is pronounced the awesome APM, but it has yet to be approved by Medicare. So CMS told ASAP that for an APM to get approved, it had to build in an 8% cost saving to CMS. So how do we as EM doctors save CMS money? By discharging more. So ASAP built into their model a 3% decrease in admissions, and they chose 4 presentations to target to achieve this, which is chest pain, abdominal pain, syncope, and altered mental status. So these were all chief complaints that, if the notes are written correctly, can be billed as a high level of complexity chart. However, for the plan for the awesome APM, it will eventually include more conditions. So for the top 4 conditions, it was anticipated that a 3% decrease admission rate would save Medicare $314 million, dollars, and an 8% decrease would save $840 million dollars per year. So let's kind of follow this model from start to finish. So the patient comes to the emergency department with one of those complaints, and the ED doctor makes a decision, and the patient is either admitted or discharged home. If the doctor discharges someone from the ED or observation, and in 30 days there's no bounce back to the ED leading to another observation or admission, then your emergency department makes money. On the flip side, if the ED discharges someone and they do bounce back or have a bad outcome within 30 days and are admitted, then your ED loses money with the model. So what's kind of built into this model is a fee for service. So any high complexity medical decision making that earns you a high complexity chart nets you $180, and that is the current status quo right now. What the awesome model does, though, is it starts to reimburse us for things that we previously didn't get paid for to ensure that services are put in place so patients don't bounce back if you discharge them. So you get compensated for your complex discharge planning, any telehealth services that check on the patient, and any home visits to follow them up at home. And again, the way the model works is that there's a risk and a reward component. So you're rewarded for good discharges, and if they come back, you get penalized. So how do we calculate the payment for your reward? It starts with calculating the baseline cost. And so this cost refers to all of the bells and whistles that go into providing care for a patient during an episode of their care and the 30 days after their discharge. The baseline cost comes from looking at the previous cost of taking care of these conditions over the last 3 years of Medicare Part A and B. And so that includes the outpatient and hospital services, and then you just average that cost out. Then you have the actual cost, which shows how much each diagnosis costs the system over the entirety of the year for the 4 presentations, extending 30 days out from the ED discharge. So, because not all hospitals are created equally, and a critical access or a public hospital may not have the same resources as an Ivy League institution, there are different ways to participate in the model. The first option is where a hospital can kind of dip their toes in and get paid just to report their metrics, but they don't get penalized if they're doing poorly. At 3 years in, though, they would be exposed to risk, and the money that they could gain from this would be 10%. The second option the hospitals have is that they can start right out of the gate without the pay for reporting period, and they would immediately be able to make 10% by doing well or lose 10% by doing poorly. And the last option is similar to the second option. However, it has a larger margin to make or lose money because instead of the 10%, the cap would be 20%. And next, we'll kind of go through how this would be applied practically. So let's take an example for how this plays out with a hospital treating patients for chest pain. The caveat for all these models is they do not take into account the overhead or the administrative cost of building the system required for these administrative services. However, if you remember our MIPS model from earlier, if you do this kind of model, you don't have to participate in MIPS, which could be a source of cost saving by avoiding any of those reporting penalties. So this is our baseline cost for chest pain based off the hospital's last 3 years, and it's reported as $5,000. And so that includes your overhead for admissions, treatments, doctor's visits, and medications. And this is our actual cost. So that's how much the patient care actually costs. So in this case, it was $5,000. So the hospital breaks even in this scenario. And in reality, they may have actually lost a little bit because they would have had to implement administrative changes and paid money to set up the system. So next we have a baseline of $5,000. And maybe in this scenario, you aren't admitting quite as many or you didn't have as many bounce backs. So the actual cost ended up being $4,000. And so that was a $1,000 saving per patient. And if you had 2,000 visits, then what you did was you saved about $2 million. And so if you opted into the 10% model, you'd make about $200,000. And if you opted into the 20% model, you'd make $400,000. And this is kind of the best scenario because you can also bill independently for all those other wraparound services like telehealth and complex care coordination. Now, the last line, if your ED discharges a lot of patients, but you get a lot of bounce backs, and bounce backs typically cost about 5 times as much as a discharge patient, then you actually cost Medicare money. And depending on your percentage model, you could be on the hook for $200,000 to $400,000 to the government. However, this is all still in the planning phase, and it was submitted to CMS and turned down in 2019 as an independent model, with a plan later to incorporate it into a larger repayment model. But we will see what happens during this administration. So let's go over how a metric is made in its overall life cycle. So the first stage is conceptualization, and this stage begins with the identification of the concepts or ideas for measures that we or our patients might find meaningful. At this point, expert panels or public comment might be solicited to refine an idea. Specification. This part involves the development of the technical instructions for how the measure is supposed to be collected and implemented in a consistent, reliable, and effective way. It specifies the data source, the population that might be studied, and what is going to be measured, and what the expected outcome is supposed to be. During the testing phase, empirical evidence is collected to help determine the strengths and the weaknesses of the measure that you chose. A trial run of collecting the evidence also lets you figure out how feasible it is to collect the data on a wider scale. And it's at this point that you would also start reporting out the measured testing. At this stage, you would identify the steps to submit your measure to CMS. This might also include getting an endorsement from CMS's consensual-based entity, which is a twice-a-year board that endorses different quality measures based off of characteristics like importance, measurability, usability, and feasibility. And at this stage, you would also determine the steps needed to take your measure from a developmental stage to an in-use stage. And so the final stage ensures that the measurement continues to add value to CMS. And during this stage, data is collected, routinely evaluated, and in some instances, updated annually. So ASAP's Quality Patient Safety Committee has a working group for the measure development and maintenance, which works to update existing measures and propose new ones. Because CEDAR is a certified vendor of CMS, it gets to submit these new quality metrics or changes to old ones directly to CMS. So now quality metrics can improve the quality of care that we provide to our patients if it's something that improves patient care. And in some instances, this may not be the case though. So this is one. PN5B was a quality metric that was very well intended and based off of two retrospective studies that linked early antibiotics with decreased mortality and hospital length of stay. And the net effect of this was that EDs began to try to change their workflow to identify community-acquired pneumonia early and treat it with antibiotics to meet this quality metric. Unfortunately, later studies would go on to show that early antibiotic administration didn't actually provide any benefit to mortality or length of stay. So the metrics that these emergency departments bent over backwards to meet ultimately didn't change patient outcome. The allocation of resources to meet these metrics might have been difficult for public or safety net hospitals to meet, especially if there's a major upheaval or restructuring of a department required to meet a metric. So it effectively acted kind of like a no child left behind of healthcare quality metrics. So to wrap this back to the awesome pathway, you can now see how this may affect each of us after residency. This is still in the planning phase, but it might work its way into how we're reimbursed. If we end up somewhere that adopts this model, we may either be empowered to discharge patients with better wraparound services or telehealth, or on the flip side is that a hospital may end up pressuring physicians to discharge patients with chest pain or abdominal pain to try to minimize their treatment costs to keep the cost closer to that baseline. So, for better or for worse, adherence to quality metrics is how we make money, and the system of reimbursements depends on non-adherence as it is a net neutral program. Initially, ASAP CEDAR was EM's answer to develop quality metrics specific to our specialty. However, with the new implementation of MIPS value programs, this may no longer be the case. And lastly, the development of these metrics depends on evidence-based medicine, but if the evidence is flawed, the metric may be flawed. And ultimately, this may lead to negative downstream effects in our EDs that can harm our patients based off of the changes that we make. Um, and that is it.